Thank you, and thank you for inviting me and then giving me an opportunity to talk a little bit about hairy cell leukemia and the new and emerging therapies, and thank you guys for coming so early to hear about hairy cell leukemia in the 8 a.m. on Saturday morning. So appreciate that. So my talk actually overlaps in large degree with what Jackie just presented. But I'll go a little bit detail some of the areas and then share some of the new data with the Vemurafenib combination therapy. So these are my disclosures. So this is what Dr. Barrientos just presented about the first-line therapy, and then you may argue that with such a striking progression-free survival, the very few relapses that we're seeing, especially with the cladribine rituximab combination, why do we need to? Is there any room for improvement in hairy cell leukemia, especially in the frontline therapy or in the relapse setting? But there are limitations, as I argue. The first-line therapy with the cladribine or pentostatin, even though they do get very high response rates of a 60 to 80% complete response and 10 to 20% of the partial response, but neither of these regimens are not curative. So, and then in combination with the rituximab, that we are getting a deeper response, and in some of these cases, of MRD negative CR, and very few relapses are happening. But again, due to very favorable course of these patients, typically that it is hard to say whether those combinations are still curative either. So we still yet to have a curative regimen at this time. And with the cladribine alone or the pentostatin, then the patients still do relapse about 30% of the time, 30 to 40% of the time. Over time, that these patients will experience relapse requiring a second or subsequent line of a therapy, which typically had been another course of Purine analogs, which then can result in further immunosuppressions and other complications that can result from those. And as I mentioned before, the high rate of MRD positivity still results in after using the single-agent cladribine or pentostatin. So what is the downside of the subsequent or the multiple treatment of the cladribine or pentostatin, as we've done in many years now at this point, is immunosuppression is one of the main things, and then possibly the increased risk of a second malignancy due to further immunosuppression and then exposure to this type of a chemotherapy. So infections due to prolonged T-cell suppressions are common, and T-cells can be suppressed for quite some time too. So even though they can recover their counts after cladribine or pentostatin, a single course of those, the T-cell recovery, if you were to follow the CD4 count and the recovery of those T-cell subsets, it can take over a year or in some cases over several years. We don't typically measure them in clinic, so we may underappreciate them. I think the population-based studies and then retrospective analysis are showing that there could be prolonged T-cell suppression, which then can have consequences in these patients of infectious complications. And the table here is illustrating some of the incidences of second malignancies. And these are difficult to interpret, actually, because as we know, that having one leukemia or the lymphoma can increase risk of a second cancers there too. And so it's a little bit unclear whether the diagnosis of hairy cell leukemia is driving the second malignancies, or is a repeat exposure to cladribine or pentostatin are driving the second malignancies. But there are the frequencies as listed here is 7.5 to 22%. So I think Jack nicely kind of laid out what are the rationale for targeting BRAF in hairy cell leukemia. So the original data did come from Tiazzi's group and Dr. Fellini's in Italy, and reporting the very high incidence of BRAF V600E mutation in hairy cell leukemia. This mutation is not unique to hairy cell leukemia. It's actually present in many different solid tumors as well, and in some of the other B-cell lymphomas too, as we now appreciate them. But they are such a highly prevalent the mutation in hairy cell leukemia, over 90% of the case. It's probably about close to 95 to 96% of the time in the classical hairy cell leukemia that will carry the mutation of BRAF V600E. So not only that, in the same seminal paper, they were able to show, and in the previous generations of paper too, I think we did appreciate that the RAF and MEP kinase pathways were constitutively activated in hairy cell leukemia too. So the combinations, those obviously do make sense. And as Jackie kind of alluded earlier, that in such a high prevalence in almost all patients having hairy cell leukemia, that suggests that the mutation itself is involved in pathogenesis. So the Omar Abdul-Wahab and MSK and then Steve Chung, and we actually then collected the patient samples to analyze where does the mutation occurs. And there are some questions about the origin of a hairy cell leukemia as well. So if we believe this mutation is in such an early or the driver mutations, where in the process the mutation actually occurs. So we actually sorted out different the stages of the hairy cell leukemia, the stem cells to mature hairy cells. And then we reported out that this mutation is actually present in hematopoietic stem cells in a very early progenitor. Again, supporting the idea that this mutation is an early event, and then targeting this mutation can result in hopefully a deeper response and then lead to cure for these patients without exposure to repeated course of the chemotherapy or any exposure to chemotherapy. So that's what led to our the U.S. multi-center study, phase 2 study of Vemurafenib as a monotherapy in patients with a relapsed refractory hairy cell leukemia. Dr. Barrientos and Dr. Rai from LIJ also participated in this study, as many centers around the country as well. And then simultaneously, Italian study also was going at the same time, and then we reported the result together. They did actually have a very slightly different study design because these were two independent studies that kind of led to initiation at a different time point. So this is a U.S. center study design, which was that we designed to the patients will get 3 months of initial therapy of a 960 milligram twice daily dosing, which is actually the dosing that's approved for melanoma patients, relapsed melanoma patients. But at the time when we're designing the study, we actually didn't know what dose will be sufficient, or whether we need to use a high dose or whether we could a lower dose. In our study, we took the concept of targeting or inhibiting the mutations or pathways strong early on to lead to less relapse rates, perhaps, and less chance for resistance, which is the rationale for choosing 960 milligram twice daily dosing. So the patients started the dosing at 1 month. We had a research study, the bone marrow biopsy, to help us assess how quickly that we are getting the response on Vemurafenib monotherapy, but the patients continue the therapy regardless of the response at 1 month for at least a 3 months duration. At the end of the 3 months, the disease response was assessed based on the bone marrow biopsy and then CBCs. And in those patients who had a residual disease or partial response, they were allowed to receive up to additional 3 cycles of Vemurafenib, so up to 6 maximum cycles of therapy. At the time, after 6 cycles, these patients stopped the therapy and then under observation. Importantly, when we designed the study, we did allow retreatments, although we didn't kind of anticipate what the relapse rate would be or the response rate would be, that we wanted to see, then leave the options for those patients who relapse after getting the 3 to 6 months of a therapy. If they relapse, they were allowed to receive Vemurafenib again. So eligibility criteria is typical for relapsed hairy cell leukemia, so they had to be either intolerant or refractory to purine analog-based therapy, such as cladribine or pentostatin, or relapsed within 2 years of initial purine analog-based therapy. These are the refractory patients. If we were to use a cladribine or pentostatin, again, these are not likely to be responders, or patients who had 2 or greater relapses. And they need to meet the hematologic parameters to indicate the therapy as listed here. So this is probably very hard to see, that this is a baseline patient characteristics of both studies. The one on the left is showing the Italian study. The one on the right is showing the U.S. study. The patient populations are quite similar. This is about 30 patients in each cohort in Italy and the U.S. These are, again, the relapsed refractory patients with a morphologic disease and hairy cell leukemia. Various degree of cytopenias, because they need to have at least 1 linear cytopenia, but they do not need to have all 3 line sounds, such as neutrophils or the hemoglobin or platelets. So this is a summary of the clinical outcome and I should actually mention in the Italian study, the study design was slightly different in the sense that they actually received the Vemurafenib at the same dose, 960 milligram, at 4 months duration, and they stopped the therapy. So slightly different duration of a therapy, and ours again was a 3 to 6 months, and the Italian study was at 4 months. So this is the U.S. study. The response rate, number of patients were 24 in our study at the time of report, and then all patients responded. It was 100% response rate, which was remarkable in this setting. This is, again, the patients who were refractory to cladribine or pentostatin or intolerant. However, complete response rate is only about 40%, so and the majority of the response was partial response. To 60%. So partial response patients, having said that, had all, in order to meet the definition criteria, they had all hematologic recovery. So they are no longer cytopenic, the neutropenia, anemia, and thrombocytopenia all resolved in those patients, but they did have a residual morphologic evidence of hairy cells in the bone marrow, thus meeting the criteria for partial response. The graph on the below is showing the time to recovery, what we can expect from the Vemurafenib monotherapy in terms of how fast the cytopenias to recover, and that we do know that in the platelet platelets are the first one to recover. So when we actually start the therapy, that we can actually discuss within a week or two, that we would definitely do see the platelet counts going up. So it's a very early response early on with the platelets. Anemia and neutropenia do take a little bit longer to recover, so usually between 4 weeks or so. So typical time, kind of similar to kind of what we were seeing with the chemotherapy-based regimens, that's the time to recover for the anemia and neutropenia. So this is a busy slide, and this is kind of it's also in our publication which we jointly do together with the Italian group. So like I said, all 24 patients responded, and either the complete response and partial response. So I guess kind of the one thing to highlight is those cross mark, which is to indicate the relapse rate. So after getting the therapy for 3 to 6 months, and we did not see the difference in patients who got 3 months of a therapy or more than 3 months, was up to 6 months of a therapy, the different relapse rates, although most of the patients only received the 3 months of a therapy. So median follow-up at the time of this report was 36 months. So as the longest patient that we followed this, at the time of report was 68 months. So we did see relapse in 21 of 31 responding patients. So about 2/3 of the patients did experience relapse, needing second line or additional lines of a therapy. So median time to relapse was 18.5 months, and then the median relapse-free survival, the 25.1 months. So this is an updated data from the kind of what we presented last year at ASH. So what happens, and as I indicated before, that when they relapse after initial exposure to Vemurafenib, they were able to receive Vemurafenib again. And when they do, and about 62% of the patients received the Vemurafenib, and the other 28% of the patients pursued alternative therapy as listed here. Some received, again, another course of Acknowledgements or pentostatin in combination with the rituximab, 3 patients altogether. 2 patients received ibrutinib, and then 1 patient received moxetumomab as a subsequent therapy following Vemurafenib. And then the 2 of those patients actually on observation, so even though that we are able to detect the relapse in the bone marrow biopsy, they really didn't require therapy based on their cytopenia was not significant enough. So the patients who received the Vemurafenib retreatment, which is 13 patients, so these are the criteria. So more patients who achieved a partial response were likely to require second therapy, as kind of expected. So about 23% of the CR patients require another line of a therapy after Vemurafenib monotherapy, as opposed to 77% of the patients who achieved a partial response to initial Vemurafenib needing a second line therapy. And Vemurafenib free interval median time was 14 months. So how did they do? So most of the patients actually did respond again. So 85% of the patients achieved a response, some response that's in combination of a CR, PR, or complete hematologic response. We're less stringent in terms of the requirement for repeat bone marrow biopsies for these patients at the retreatment time. So that's the reason for CHR, complete hematologic response, for those patients who were not able to or didn't obtain the bone marrow biopsy. So this is interesting, the fact that they are, even again, the repeated course of Vemurafenib, kind of similar to how our patients with hairy cell leukemia behave with repeated course of the Acknowledgements pentostatin, that they are again gaining the response, kind of suggesting the acquired resistance to Vemurafenib monotherapy is a relatively rare event. Dose that we have used in the retreatment time was variable as listed here. So most patients are receiving 480 milligrams twice daily. That dose reduction is usually required by the side effects, most commonly arthralgia and rash. And duration of Vemurafenib retreatment is median time was 9.4 months. So when we also started retreatment, also it's unclear how long to continue Vemurafenib at this time after failing the 6 months of a therapy. So I actually have a various duration of the patients. I do have a patient who's on Vemurafenib monotherapy over 3 years at this point at 240 milligrams twice daily, who's doing very well. And then there's another patient who I did it for 1 year. We stopped the therapy because he has a complete recovery of the blood counts. And the bone marrow biopsy at that time of at the end of the treatment after 1 year, that he still had a partial response residual hairy cell leukemia, and then he again relapsed a year later, and then we restarted the Vemurafenib, and he responded again, and now I'm continuing on the therapy. So we're still learning how to use Vemurafenib in the retreatment setting and the total duration of a therapy. So this is a clinical course kind of over time. So again, this year most patients did respond, but there are some relapses that we do see requiring second line of a therapy, additional line of therapy. So the side effects of the Vemurafenib is real, and although the vast majority are really manageable, and these are oral therapies, which is a huge plus for this patient, so 0 IV exposure. So the most common side effects are rash and arthralgia, so really the two predominant symptoms that led to the dose reductions, and these are the more common ones. Again, these are quite manageable, either dose interruptions or dose reductions, or in some cases of a very short course of a steroid, the prednisone 10 to 20 milligram a day for about a week course is usually sufficient to resolve this toxicity. Other toxicity to keep in mind is photosensitivity. So these patients, which is known side effects, it's the same side effect profile that we are seeing in the melanoma patients and other cancers. So really no abnormal toxicity that we have seen, or no additional heme toxicities with the Vemurafenib in heritage leukemia patients. So we did have one acquired case of a resistance to Vemurafenib, which again, I mentioned before, the repeated course of Vemurafenib, these patients were again able to attain the response again. But one patient did require a RAS mutation, KRAS mutation, during the short course of the drug-free interval, and he was actually developing in a retrospect when we analyzed the data toward the end of his therapy that he was already developing KRAS mutation, and then which led to the drug resistance. But this was actually the only one case of all the analysis we have done that we found a resistance mutation. So while we do believe that they do exist, but these are a very rare event. So based on that data that we actually have embarked, if the Vemurafenib combination works very well in the monotherapy in the relapse setting, and then next Jackie showed the Italian data, so Vemurafenib plus rituximab in the relapse setting, that these data also are getting a much higher response of nearly 100% CR rate as opposed to 40% CR rate that we're getting with the Vemurafenib monotherapy. So we actually now designed and doing Vemurafenib plus obinutuzumab in the front line in the previous untreated heritage leukemia with an idea that can we replace the chemotherapy altogether in heritage leukemia patients, and such an early mutation, early event, the BRAF analysis, maybe we have an opportunity to cure heritage leukemia with a 0 chemotherapy exposure. So that's the idea behind the study. The primary objective of the study is to determine the efficacy as assessed by CR rates, and we are doing the MRD analysis by immunohistochemistry, as well as BRAF, the digital PCR to allele burden. So the design of the study, Vemurafenib, the patients are taking for 4 months, and obinutuzumab starts 1 month after to reduce the risk of obinutuzumab infusion reaction, because based on our previous data, by 1 month, that we are able to eradicate most of the heritage leukemia in the bone marrow biopsy, so the infusion reaction has been low. So the inclusion criteria is listed here. So this study is open at MSK, then at Harvard Yale is an ongoing study. We treated 14 patients to date, and they will present this data at ASH this year, so I'm not able to show the details of the data slides, but I can tell you that 14 patients we treated, 9 patients evaluable, and then all patients did respond and all MRD negative. So we're, the therapy does appear to work. It's a very promising therapy, so we're kind of excited about this combination. So this is a moxetumomab data that Jackie already presented, so which is, but I'm not going to go into too much details, but this is another indication for therapy targeting CD22, that this is immunodrug conjugate with a Pseudomonas toxin that's attached to CD22 monoclonal antibody. So this is definitely an option for those patients who, relapse refractory patients, chemotherapy-free options, and this is IV infusion that's given day 1, 3, and 5, then going every 28 days for up to 6 cycles of a therapy, and 40% of these patients were able to attain a deep response. So this is also kind of an option for our patients as well. And the hematologic recovery time, which is in the paper that Dr. Retreatment published in Leukemia, that appears to be quite similar as well too. So it's early recovery of the counts within 4 to 6 weeks period of the time. And then the box on the forest plot, if it's hard to see, that just to highlight that some of these patients did receive a BRAF inhibitor, such as Vemurafenib, most common. The other common BRAF inhibitor that we have used is Vemurafenib. But about 6 patients out of the 14 patients that did get a BRAF inhibitor, and then there's no difference in the response rate, whether they got a Vemurafenib exposure prior to getting moxetumomab. So certainly this could be an option for those patients who have failed or are resistant or not able to get BRAF inhibitor. Adverse event, Jackie already kind of presented, so I won't go into too much details. And then ibrutinib, the data she also presented, so there's a lot of overlap there. So again, this is an option, but compared to Vemurafenib, plus Vemurafenib with a rituximab and moxetumomab, ibrutinib as a single agent hasn't get as good of a response. So there are some CR patients, about 4 CR patients in this series, but overall response was about 46%, which is a little bit lower. But again, this is an option for those patients who have a probably failed or exposure to these therapies are not able to get them, but this won't be, usually we don't use them as a first-line therapy, and it still is not approved therapy yet for the hairy cell leukemia, although it's used commonly in other disease settings, as we know. So in conclusion, the Vemurafenib monotherapy, as we've seen, is highly effective in relapsed refractory hairy cell leukemia, with the vast majority achieving a response, about 40% or 30 to 40% complete response rates, and dose reductions are often required due to side effects such as arthralgia and rash. So the long-term follow-up do indicate that the patients do relapse after Vemurafenib monotherapy, although they do respond as well to repeated course of Vemurafenib, although the total course of a duration do remain unclear at this time. We are excited about the obinutuzumab combination in the front line to see whether they could be any better than cladribine rituximab combination. So maybe we'll have a randomized studies to answer that question or not, and it's a relatively rare disease, so I'm kind of excited to see, but we are excited about the opportunity. And the moxetumomab, ibrutinib, as I mentioned before, do present an opportunity, another therapeutic opportunity for these patients with the relapsed refractory hairy cell leukemia. This is my acknowledgement slide from the Center of MSK that which I belong to, and the Hairy Cell Leukemia Foundation, Leukemia Lymphoma Society, who have funded our research with the Vemurafenib combination therapy too. Thank you for your attention.